Okay, 6 o'clock, we'll get started here. So anyone that just joined us, if we can get you to push mute in the bottom left-hand corner. And your videos as well. Thank you so much. So hi everybody, my name is Julia Alton. I am the Executive Director of the Canadian Fabric Association. So this is a unique project that we're doing because we have both the US and Canada on together, which is exciting because we're all in the same boat and all learning together. So why not maximize on doing this together? So I'm proud to have both Jerry Walter with me and Jack Johnson. And Jack, I'm going to just have you introduce yourself and just say the name of the organization, just for anybody who's on the call that doesn't yet know you, and then we'll move to Jerry.
Jack Johnson here with Fabry Sport Information Group. A Fabry patient and executive director of the organization, which we got started back in '96. So.
Perfect. Thank you so much. And Jerry?
Hi, everyone. This is Jerry Walter, founder and president of the National Fabry Disease Foundation. And it's so nice to see all these familiar names and faces as they flash in front of the screen for a second. So good to see everyone. Glad to be here. Thank you, Dr. Khan, for being here.
Wonderful. Okay, everybody. So if you're not familiar with Dr. Khan, here he is. He is such a big part of the Fabry community. He works tirelessly to make sure that Fabry patients have great opportunities, and he spends so much time putting his heart and soul into Fabry. And we want to make sure. I'm just going to take that video off. Hi, thank you for joining. And he's with us today, and he has a wonderful slideshow ahead. So most importantly, this is education, and we want to make sure that if you have any questions that they get answered today. Dr. Khan has a wonderful way of being able to take complex ideas and simplify them. And so this is what this is all about. It's for us to be able to have the opportunity to learn and get educated on the subject. So Dr. Khan, throughout the session, if our participants have any questions, would you like them to save them till the end and we can take them up together, or are they willing, or can they ask throughout it?
Yeah, I think why don't we save them till the end?
Yeah, sounds great. Okay, everybody, so just write those questions down, and at the end, there's a little chat session. I'm sure we're all getting quite comfortable with Zoom these days, but at the very bottom of your screen, you will see chat. So at the end, we'll take those answers up, and we can have a little bit of an interactive conversation if we have questions. So Dr. Khan, without further ado, thank you so much for joining us and for your time today. And I'll hand it over to you.
Thank you so much. And I will do share screen. I think you may have to enable screen sharing, I think.
Yes.
Again.
I don't have my video on.
Let's try it again. Okay.
Did it work for you?
It's still giving me, let's try it again. It says host disabled, attendee screen sharing. I'm sure there's a settings.
Yes.
Yeah, go ahead. I'm sure you'll find the setting, and then we can. You are the host now. Oh yeah, that's right. That's how you do it in Zoom. You switch hosts. Okay, let's try this one. Yep, this is the one. Okay. Do that, and I maximize it so everybody can see that.
Yes.
Yes.
Okay, good. So thank you very much, Julia, and to the CFA for the invitation to talk today. My name is Anil Khan. I'm Professor of Medical Genetics and Pediatrics here in Calgary. And today we'll be talking about gene therapy for Fabry disease. It's an educational session. So my presenter disclosures, various grants, travel grants, advisory boards that I've been involved with. And also just related to this product, I do have a royalty agreement for Fabry gene therapy with the University Health Network, and I'm on the CFDI advisory board. But I will be talking about the technology. It's an educational session. I'm not endorsing any particular product or company, and I'm not indicating any preference for one method of gene therapy over another. And when I use examples, it's because we're involved in a clinical trial. There are some slides from that trial from AvroBio, but that's not an endorsement of any particular brand or product. So let's go to the very basics about genetics. And we know that our bodies are made up of millions of cells, or billions of cells actually. And so cells, something you can see through a microscope, it contains genetic information, which is the blueprint on how a cell functions. And that's located in an area of the cell called the nucleus. So if you look at the nucleus, you see these structures we call chromosomes. Chromosomes are really packages of DNA. So you look closer into the chromosome and you will find DNA, and genes are segments of DNA. And so if you look at genetic diseases, it could be due to a change in a gene, one portion of a gene here, or there could be larger regions that are abnormal in a chromosomal region. And then in some circumstances that can lead to a particular diagnosis or a particular disease. So that component of genetics is important to understand when we look at gene therapy, because many of you have probably met your doctor and your doctor said, well, we have a treatment for gene therapy, but we don't have a cure. And that's because, the original change in the gene that produced the Fabry disease, at the time that you had that conversation, there wasn't any way of correcting it. That's what people have traditionally called a cure. But you can look at a cure in different ways too. It can also be, do you have absence of disease symptoms and so on. In the cancer world, if somebody got cancer and they were treated, on average, cure is considered 5 years without the disease. So now, though, we have technology where, now this isn't yet in clinical trials for Fabry disease, where you could correct the change in that particular gene. But in most cases with gene therapy, we're actually replacing it. We're bringing a new gene in. We're not actually replacing the old gene. So keep that in mind when we talk about these different gene therapy methods. So in Fabry disease, what's really happening is you have deficiency of this protein, which is an enzyme called alpha-galactosidase. And this particular reaction from GL3 to GL2, where you basically get rid of a galactose, which is a type of milk sugar, this reaction doesn't happen with the efficiency that is needed to stay healthy. So you get buildup of GL3 or GB3, and that's one of the components of the symptoms of the disease. So remember we said that proteins, right? The proteins are really being produced from this DNA. So if we were to change the instruction on the protein, then you could change the protein, increase the amount of the protein, do some correction, and maybe then correct the buildup of the GL3. So that's the general concept with any metabolic disease. And with enzyme deficiency diseases and metabolics, the idea is if we get the enzyme into you, then maybe that will do the job. Or in some cases, if you take a medication that increases the ability of your own enzyme to work, let's say it's not working 100%, then that might help too. Although typically you don't need to have the enzymes working 100%. Really, when you're below 1 to 3% activity, you really see the symptoms of the disease. So in many cases, you don't have to do 100% correction. You can just do a partial correction, and that may be enough to make a significant change. So does a healthy gene do? The way it works is the DNA is your blueprint, okay? So think of that as your bank account. You have a bank account, you need to take some money to go buy something, you've got some project, a go-kart you're gonna make, right? Your RNA takes a copy of the DNA, and that represents the code, and then it goes and produces the the instructions, well, it has the instructions for these amino acids, how they're going to make that protein, the alpha-galactosidase A. Right? Everything works properly. The genetic code doesn't have any major changes in it. The protein works. You don't have Fabry disease. If it's not working, then it's likely because there's a change in the DNA. Now, there are many different ways of having a change in the DNA. The ones that we're talking about for Fabry disease are really the code is changed. So if I have the instructions, please go to the store and get 1 pound of potatoes, and now I put 2 zeros after the 1, you can see that's going to make a big change. 100 pounds of potatoes, right? So the genetic code is really a set of instructions, and you can have what looks like a very minor change in the code, but it actually, when it gets down to the protein level, can change the shape of the protein, it can change how it works, and it may not work properly. And that's, most of the time, that's how people get Fabry disease, is there's a change in the DNA code, and at the end of the day, the protein doesn't work. So when we talk about enzyme replacement therapy, you're getting an engineered protein that then goes and chews up the GB3, for example. When you're talking about a chaperone, it's helping this protein work better, or protecting it from being degraded in the cell. When we're talking about gene therapy, again, we're not yet at the stage clinically where we're correcting this gene, but we're putting a different copy of the DNA in that can then produce a protein that works a little better. And the signs and symptoms of Fabry disease, as you know, include cerebrovascular disease, stroke, heart disease, cardiomyopathy, kidney disease. But also you can have other symptoms like reduced sweating. You can get those lesions on the skin called angiokeratomas. You can have pain, which is one of the most debilitating symptoms, which can be in the GI tract or at the ends of the limbs. And we know in terms of cause of death, currently, used to be at one point the kidney disease would cause death. But as one nephrologist pointed out to me when I was training, he said, Anil, remember, you can live without your kidneys, but you can't live without your heart. So, so now the heart disease is really the major cause of mortality in Fabry disease. And the standard of care is there's 2 available enzyme products. We're talking about Canada here, alpha-galactosidase alpha and, agalsidase alpha, agalsidase beta. And in Canada, we also have available megalostat, which is not an enzyme, but it's a chaperone. It's helping protect that protein from degradation so that your own protein may be getting a bump in its ability to recycle the GB3. So those are standard of care. Gene therapy is not standard of care, so we're talking about research when we're talking about gene therapy for Fabry disease. So what is gene therapy? So in the modern sense, we're either replacing, inactivating, or adding new genetic material to make
Good, how are you doing?
in the biological properties of the cell. So, and so here you can see 2 examples. One is called in vivo gene therapy, where actually the gene therapy, the new gene is put inside of a virus, and an inactivated virus, because viruses like to stick genetic material into cells. That's how COVID replicates. It has a piece of genetic material. It's an RNA virus. So somebody coughs, you inhale the stuff, it goes into your lung epithelial cells or other epithelial cells, and then it makes copies of itself and makes you sick. So viruses love injecting genetic material in. Now, we don't want you to get an infection from this, so the virus is inactivated in the sense that it's not going to keep replicating, but it's now being used to just inject the genetic material. And in vivo means you actually inject that vector, and the vector is the name of what that virus is altered into for the purpose of injecting genetic material. So there are various ways to do it. So you can have a vector that's a virus. AAV is not really used anymore. They have newer ones. Or you could do it with a layer of special fat. So a lipid nanoparticle.
made a
I'm
decision
just wondering if you're not mute, if
to
anybody,
go and
everybody
ask
can
them
mute.
to keep it open until October 1st.
I think as a
And-
host, there might be a way for mute to mute.
Yes.
And
Hi,
bank on success, which we think is really, really high risk,
Catherine, can you mute?
right?
for everybody who's on the call, there's a mute button on the bottom left. If you can just push mute. Dr. Khan, I'm just going to take over host for 1 second,
Sure.
just to mute everybody because I can't over, yeah, just for 1 sec. Okay.
Okay,
Okay.
can you see this? Can you see the slide?
Yes.
Okay, you can hear me? Okay. So when there's a direct injection of this material, that type of gene therapy is called in vivo gene therapy. So it's an important thing to remember that this is one way of delivering the genetic product.
Yeah.
The other method is what's called ex vivo gene therapy, where we don't inject the material directly into you. We harvest stem cells, and then we inject the genetic material into those stem cells. Then the vector, so we don't use the term virus because it's not something that replicates. The vector is eliminated from the culture, and then those cells are put back into you. So there's no direct injection of a vector back into the person. It's the gene-corrected cells that go back. So those two terms you might hear about when you're hearing about gene therapy trials: in vivo and ex vivo. So, and then that'll be relevant when we go through some of the further slides. Okay, there we go. So, I'm just trying to, I don't know if you're seeing the other people, but I'll just minimize that. So gene therapy is actually not new. Okay, so if we look at general history of gene therapy trials, and this covers more than just gene therapy trials, we know for certain condition, which is technically a metabolic condition, severe combined immunodeficiency syndrome, where your immune system is compromised, that, you know, back in 1970-ish or earlier, that the treatment was what's called a stem cell transplant or a bone marrow transplant. When it's coming from somebody other than yourself, that's called allogeneic, meaning you have somebody else's cells that replace your bone marrow cells. So that was the general treatment. So the main difference between that and ex vivo gene therapy would be you're getting somebody else's cells instead of your own cells. They contain a working copy of the gene because the other donor presumably didn't have the disease, and that's been the general method to correct severe combined immune deficiency. It's also the method we use to treat early onset Hurler syndrome. It's a bone marrow transplant that's being done. And then you get cloning and viruses. The early gene therapy trials used what are called gamma retroviruses, and so on. And so we hit this point where, you know, the technology was present to show that you could transfer the gene. You moved from a period where it did not show any clinical improvement to then for the SCID trials where you showed clinical improvement, but you'd notice there was some toxicity with that particular technology, and that things have improved and changed to now where you can achieve a clinical improvement and you can also make it safe. That doesn't mean it has to be safe or that it is safe every single time. All those risks and concerns have to be taken into serious consideration, but we are in the era where it can be safely administered in the majority of settings. A lot depends on the details of that particular trial, and that we're now able to use it in applications for metabolic diseases. It's been used for hemoglobin disorders and other disorders as well. So that's the era we're headed into. We've moved on from the earlier stages back here. Oops. Okay. So when you hear about these viral vectors, then you will hear about different types of vectors. And I know some of this is technical, but especially if you're looking at participating in a clinical trial, then some of this information might help provide a background behind these terms. So remember I said the earlier types of gene therapy used what are called gamma retroviruses, and these really aren't in the majority of the gene therapy trials that are coming about. What you remember, we said you have billions, if not trillions actually, of cells in your body. So if you wanted to correct all of them, you would need trillions of particles. So you had to have high titer production for those sort of experiments. You also want a high percentage of those vectors to transmit the gene into the cell. That's called transduction. And for gamma retroviruses, you would use dividing cells. So you would have to use stem cells, cells that came from the bone marrow primarily. So that's why it was used in SCID. But these particular vectors, they had a higher rate of integrating to increase the what are called proto-oncogenes or cancer-causing genes, or genes that might then lead to increased risk of cancer. So they would like to, it's kind of like sitting next to, you got onto a bus, inserted a gene, you got onto a bus and you sat down to somebody who had bad tendencies and was likely to punch you or something like that. So they just happened to go into the bus instead of picking the empty seat. They would like to pick that other seat that had that person. So things have come along a long way. So, so that would be used for ex vivo. AAV named vectors, and there's many ones, AAV8, not plain AAV anymore, but the AAV8, AAV2, AAV9. Most of these are liver targeting. Some will also target the central nervous system. They target non-dividing cells. So if you had a liver disease, I'll talk a little bit about a liver disease, like a urea cycle disease, and you wanted to apply that to that disease where you have to now change a percentage of liver cells with gene therapy, there's a lot of cells, you're going to need what's called a lot of vector. So high titer will be required in these circumstances. So the other group, major group, are what are called lentivirus vectors. So lentivirus vectors have what's called less genotoxicity. They tend not to want to go and sit next to the guy on the bus that's going to punch you. So they can integrate into non-dividing and dividing cells. That's important because bone marrow cells, especially when you look at Gaucher disease is a disease of what we call the hematopoietic system, so your bone marrow stuff. Those are dividing cells. If you want to target dividing cells and you want to use a vector, you could use a lentivirus vector. AAV is not going to go into rapidly dividing cells as efficiently. You would use these in liver cells where they're non-dividing cells. But lentiviruses can go into both, but they have a good application in dividing cells, so stem cells. And you can put in what are called self-inactivating elements, so shut-off switches, and you can modify them many different ways so that they don't turn on the genes next to the bus. So it's like going down to sit down. Even if you sit down next to the guy next to the bus who's going to punch you, you brought along a cupcake or something else that will make that person a little less excitable. And now, because you are putting them into stem cells, and what stem cells like to replicate themselves and make many copies. You actually don't need to produce as much virus when you go into stem cells because the stem cells are going to reproduce themselves. That's what your bone marrow is doing all the time. That's why you can donate blood and you don't have to worry about it because your body's constantly making blood all the time. So keep that in mind. So lentivirus going into dividing cells like bone marrow cells will need a low viral titer, and that's part of what we call ex vivo gene therapy. Okay, so I'll give you an example. We did use in vivo gene therapy with what's called an AAV8 vector to treat this patient with a urea cycle disease. Urea cycle disease is primarily involving problems related to the liver. So this was a direct injection and it produced increased copies of a working gene into the liver. The patient went off their ammonia scavengers, has been on unrestricted protein, normal ammonia levels for more than a year. Of course, we had to use a high titer, 10 to the 12. Just keep that in mind. It's the titer we use for ex vivo is 10 to the 6, or worst case scenario, 10 to the 8 depending on the weight of the patient. But nothing close to this. There's orders of magnitude higher, because you have to, unless you get it into a certain percentage of the liver cells, you're not going to produce any real clinical change. So direct injection, liver, AAV8 vector, that's what it's supposed to do. In this particular case, we didn't have to put it into stem cells or non-dividing cells. It went into liver cells. Liver cells are already mature cells, and so it can be used for that. Okay, so let's talk about ex vivo, or stem cell gene therapy. It has a few more steps. So what we do here is we take stem cells from the patients. So if we took a blood sample from you, there are stem cells in the blood sample. So we can take those stem cells. Now, we do what's called mobilization, which is you take injections of a medication that produces more stem cells, because if we just took the amount of stem cells that are in your circulation right now, that's not enough to give back to you as a transplant. So we need to make tons of them. That's why you go through a period, usually about 4 or 5 days, where we give you medications so that your bone marrow makes more stem cells. We harvest the stem cells, your own stem cells. Okay, and then in a lab, we put in a working copy of the gene. So now that stem cell has a working copy of the gene. It's a Fabry disease gene. Now it's going to make alpha-galactosidase A. Excuse me. And then you get your own cells back. You're not getting somebody else's cells. You get your own cells back. They have a working copy of the gene. Because they're your own cells, they're not supposed to attack your immune system, and vice versa. So we don't need the immune suppression that you would give if you had somebody else's stem cells, or what we call an allogeneic transplant. So less toxicity from not needing that component by using your own cells. And we know that cells through a bone marrow transplant or stem cell transplant can have some effect in the nervous system. So we know that because that's what we do for Hurler syndrome. For Hurler syndrome, we like to have the transplant usually under 1.5 years or 2 years before they show severe neurologic symptoms, because some components of what cells go into a bone marrow transplant will eventually make their way into the brain, and then you get replacement of that enzyme in the brain. So that's been using it for Hurler syndrome for a very, very long time, more than 3 decades. So some conditions which might, where you might have a neurological component, theoretically, with a bone marrow a transplant or a stem cell transplant, it will take a little longer. It's not an immediate effect, but there could be ways to target what's happening in brain tissue as well. Now, some of the in vivo vectors, so the AAV9s, for example, will also target nervous system. So there are ways to do that depending on which type of vector that you're using. But in some diseases like Gaucher disease, which is a disease of macrophages, for example, and monocytes, then you can directly target that particular cell type with ex vivo gene therapy on cells, stem cells. The type of stem cells that we harvest are a particular type based, we won't go into how they're typed. They're called CD34 stem cells. CD34 stem cells will make any type of stem cell when you inject them back. That's what a stem cell, one of the properties of a stem cell is it will make, actually eventually convert to red cell producing stem cells, to white cell producing stem cells, to platelet producing stem cells. So you replace the function of the bone marrow using these particular cells, CD34s. So this particular trial, so we're the only Canadian center with this trial, but it's available in Australia as well. It's open, and this is an ex vivo trial. These are the criteria for that trial: people with classical Fabry disease and who have not had enzyme replacement therapy or chaperone within 3 years, because you want to see that the treatment was doing something. If you do it on top of an existing treatment, then it's really hard to tell. And you can check with them to see when recruitment in the US will be open, but I know there's a number of centers working on that right now. And so what is the process involved with that trial? So remember I said we wanted to collect your stem cells. So we use medication to increase production of the stem cells. That's called mobilization. So we mobilize, get the bone marrow to start making tons of stem cells, and the bone marrow will throw it into the circulation. Then we put in IV lines, and we basically remove the blood, filter the cells out. That's called apheresis, and then put the blood back into you. So it doesn't take 70 days. Don't worry, you're not on it for 70 days. It takes 1 or 2 days, but it's that's the phase of the study between, you know, getting all your tests done and then going through the mobilization component, which is 4 days of giving the medication, which you inject by yourself under the skin, and then you have 1 or 2 days where you filter those cells out. Most of the time is just getting tests that the doctors ordered done. You need your ultrasound on this day and you need an MRI on that day. It's not 70 days of going through it. And then there's what's called conditioning to prepare the cells, prepare the body for the gene-corrected stem cells to come in. The reason why we do that is, you can imagine if you went out to the furniture store and got a lovely furniture suite, but you still have your old sofa, love seat, and couch at home. Where are you going to put it? And the way bone marrow transplants work is, if you don't create space for the new cells to come in, you won't get them to stay, called engraftment. So if you wanted to, you could use that strategy with relatives you didn't want to stay. But for bone marrow, that's what you have to do. You have to remove the old furniture before the new stuff is going to come in. That's called conditioning, and there are medications. In this particular tribe, busulfan is the medication that is used in the conditioning to prepare the body for the new cells coming in. And then once the conditioning is completed, you're in the hospital at this time, then you receive your gene modified cells after the conditioning is completed. And it's basically an IV infusion. It's quite anticlimactic. It lasts less than 20 minutes. It's just straight infusion. Now you got the stem cells in your system, and then you're in the post-infusion period where now we're waiting for those cells, the new couch to find its way where the old couch was in that living room, and to set up shop and start replicating and making copies of itself, or what we call engraftment. So that period, of course, a follow-up for that is we expect engraftment usually to take place within a month. Oftentimes is a lot earlier than that. And then that's it. You're discharged from hospital, and you keep coming back for follow-up visits just to make sure that everything is okay and has worked. So that's basically, in a nutshell, what an ex vivo trial looks like. So with this particular study on naive patients, this is kind of a rough timeline to get through the study. So day minus 60 means you use the minus because it's 60 days before the transplant day. You start to enroll in the study, consent form, get various things completed to prepare for the conditioning, which is about 4 days of the medication for conditioning, then apheresis. So then after that, you would come back in about 2 months or less later, have the conditioning to make space for the new stem cells, get to the infusion with your gene-corrected cells, and then go on for follow-up. Okay, so conditioning, like I said, it makes space for new cells. The dose is very carefully decided based on the weight and the height of a person. We want to look at the total dose. We do a slightly different calculation than what you might be used to for your enzyme or chaperone therapy, because we do it's based on an accumulated dose. So you get some blood work done through those stages to look at what your accumulated dose is. The main one being used in this trial is, well, not the main one, the only one being used is busulfan, 4 days of busulfan. It's a conditioning medication. Busulfan is widely used across the world for people who get stem cell transplants for cancer. So if somebody had leukemia and they needed a transplant, or some other cancer where you have to kill the cancer cells, then busulfan is one of the medications used to clear space before they get new cells. So there's nothing in the trial that's new with respect to that. This is something that's done thousands of times a year around the world, giving busulfan for a stem cell transplant. So the main side effects from getting busulfan: nausea, vomiting, diarrhea, mouth sores, pain in the abdomen, fatigue, nosebleeds, headache, sometimes a rash. The two other major risks from busulfan are sometimes seizures. So people are given a seizure medication, even if they don't have seizures, just to help reduce the risk of getting seizures. We don't know that they're going to get them. It's just something standard that we do. And there can be an increased risk of certain blood clots, so they will be put on blood thinners during this process and be monitored very carefully. And you know, when you get a regimen like that, it could impair your fertility. So there is banking of egg or sperm before you start the process, depending on what stage of life you're in and whether you want to save these cells for reproductive use later in life. I'll just give you a little bit about the FACS project, which was the Fabry trial before the existing trial. Well, it's still part of the AVROBio trial group now, but many of you may have heard about that, mostly because we have some data that on a slide deck that we can share with Dr. Medine as the principal investigator, myself here holding fort in Calgary, right? And so we measure things like we said at the beginning. One of the things, if you have Fabry disease, is your level of enzyme activity is low. Now, in these trials, the trials for Fabry disease, because it's an X-linked disease, are recruiting males. And one of the reasons for recruiting males at the early stage is one of the main things we're looking at, whether it works, is whether we cause an improvement in enzyme activity level. In females, as you know, enzyme activity in Fabry disease cannot be used to, or it can be quite variable, so you can't reliably use that as your outcome variable. You could use disease markers and things like that, but at the early stages, the goal was to see, could this gene therapy cause an improvement in enzyme levels? So these are 5 patients in that FACS trial. The longest one out is this one, and you can see we gave the stem cells, right? So we just gave a big injection of stem cells. They will live around for a certain amount of time and eventually settle down to what's called your long-term graph. What's your long-term enzyme level? And at some point in this particular patient, you can see it was dropping. We're biting on nails, hoping it doesn't continue to drop, and it started to level off. So you could look at that, and this is the reference range for the enzyme levels. Remember I said, though, you don't really need a lot of enzyme to reduce the symptoms of the disease. So this is still above the minimum level where you would say somebody had Fabry disease. So it's still producing enzyme that if you took somebody who never had the disease and you did a blood test on them, you would not conclude that they had Fabry disease because they have enough enzyme activity left over. So it did level out, and now it's kind of staying where that is, which seems to be what I call, in a general sense, enough. They're like, well, how much, if you ask the question, how much do you need to boost enzyme activity? There's no numerical answer. So the general answer I use is enough. So maybe that's enough. We'll find out from a long-term trial. And some of the other patients, they're at earlier stages, so we don't know what the curve's going to do. This one looks to have leveled off right here, which is a superb amount of enzyme. Some people are still above in the normal range. We'll see what they do. So this is not unusual for a bone marrow transplant, is that your early correction looks to be a lot greater because you just put a whole bunch of stem cells in that had the gene therapy product. It's not unusual compared to what we see in Hurler syndrome. When we look at the mucopolysaccharide excretion immediately after a transplant, you will see an early initial reduction, and you might see a rise in levels later on, but they are still grafted well, and they're not showing any symptoms, progressive symptoms of the disease. So as you can see, in all 5 of those patients, we got some degree of enzyme correction. In all of them, at least enough enzyme correction that they wouldn't be considered deficient. And oh, that was plasma. These are white blood cells. You can see here we got a little closer to the normal range for everybody. And over time, they'll continue to be monitored to see how that looks over time. Some of those patients are not taking their enzyme anymore. So that's a component of the trial. The new AVROBio trial is that you would go off enzyme replacement therapy. So I've hammered a lot of information. We're going to kind of wrap it up, and I thought we'd leave a generous amount of time for questions. But you know, when you go through a trial like this, there's a large management team that's involved. There's the interventional geneticist team. I guess that's a term I guess people like me use sometimes, where we're not just describing the genetics, we're actually intervening and trying to change the course of the disease. Research coordinators, large team involved there. There's the bone marrow transplant physician service that's involved, and you can have metabolic specialists involved. If you're coming from a different town, it could be a specialist that your interventional geneticist or your principal investigator communicates with, your primary care doctor, other specialists that would be component of your care while you're being looked after for one of these studies. So in summary, most gene therapies are in clinical trials. A few of them have been approved, like for spinal muscular atrophy. You probably heard that gene therapy was approved, metachromatic leukodystrophy in Europe, depends on the jurisdiction, and also for severe combined immunodeficiency. And if you add them up, more than 1,000 people have been treated with some form of a lentiviral vector in a gene therapy trial. It's not as new as you might think. And is it possible that a single treatment, a single dose of a gene therapy could treat low enzyme activity for Fabry disease? I think that's what we're trying to figure out. That's the main question. You get a single treatment. Is that enough now to give you enough enzyme activity for the rest of your life? That's the question that we're asking with these studies. So with that, there's a snapshot night time of Calgary. Last year we had the Stampede. This year we don't, for obvious reasons because of COVID. So we'll just look at the picture and remember things. So with that, I think we can go into the discussion session, and Julia, you can take back control, and I'll try to answer questions.
Okay, thank you very much. That was wonderful, as always, and thank you so much for explaining. There's a lot of questions that I actually had throughout the presentation, but you've answered most of them. There is one that someone just asked, are you able to just explain one more time why females aren't included, and do you think they will be, in the long term? I know, yeah, and how we can't measure that, yeah.
Yeah, so it only has to do with the fact that in females with Fabry disease, the main outcome measure, which is a change in enzyme activity, we know in females, the enzyme activity does not relate to how deficient the enzyme is in the cells. It can't be used as a measure. So the males are used because there is more of a direct correlation there. And when you're trying to prove that the gene therapy corrects enzyme activity and trying to get it through all the different regulators, you have to use a model where you can prove that, yes, it does do something. So I certainly see no reason why there cannot be trials that involve female subjects once we get past the first few phases where the agencies can say, okay, you did the gene therapy, the enzyme activity went up in the males. We know you can't use that as an outcome in females, but go ahead now, you can go and use the cardiac measures, you can use the kidney measures and things like that. So it's just about the stage of the study. I mean, in the Gaucher trial, because it's Gaucher's autosomal recessive, doesn't matter if you're male or female.
Wonderful, thank you. That's great, yeah. Can you say what dose was used in the trial?
Yeah, so our target dose for most of these lentiviral trials is 2.5 times 10 to the 6 cells per kilogram. There are some more calculations that go in there in terms of what percentage of those cells had the vector in them or transduction. So, but that's the usual target, which is the same target for any bone marrow transplant. It's no different.
Okay. It was mentioned that the study is being conducted to see if the single treatment can help people who have low levels of enzyme. What about those who have 0 level enzyme activity as part of their disease?
Okay, well, that's a good question. So it doesn't exclude people because it's 0 level of enzyme, which in I guess the language I use, 0 would still be low. So there's no exclusion based on that. But if there are high antibodies to, if somebody received enzyme therapy in the past, for example, you can imagine, because there's a lot we still have to learn about doing this, that if we did that replacement and they got a really bad reaction because their body is making antibodies to the product, this is a hard thing to undo. It technically can be undone. The ex vivo can be undone, because what we would have to do is basically ablate your bone marrow, similar to a cancer patient, and then we keep what's called a backup graft. The backup graft is your unaltered stem cells that we give back to you and go back to the way things were. It technically can be undone, but if you were developing a reaction from the bone marrow transplant to those cells, we don't know. That's going to be a continuous thing. I mean, if you had an enzyme infusion reaction, you could shut it off. Now, some studies are showing, though, when you do something like this, you do an ablation or a conditioning regimen, that it's possible that it might shut off your antibody production. We have to get some more data before that stuff can be built into some of the new recruitment components. So if you have no enzyme activity and you don't have antibody production, it doesn't exclude you from the trial. But if you have had severe infusion reactions, then for many of these trials, that is an exclusion criteria, because we have to wonder if we go ahead and give you the new product and you start reacting to it, that's going to be that could be a possibly continuous reaction. So I know the data from Duke University and Dwight Kerbel, who's talked about this at Garrett meetings, has said that animals that produced antibody before the gene therapy, and that's a in vivo gene therapy, do not produce antibody after the gene therapy. So there's some concept there that maybe, I don't know, you reset the antibody production response, but we just don't know enough about it. There are methods being used for some of the trials to suppress the general antibody response as well. So might take a little bit more time to see how those patients are handled.
Okay. Can gene therapy be applied for young people, do you think, in the near future? Sorry, specifically 16 years and younger is what
16 years and younger?
Yeah.
Well, I mean, unfortunately, a lot of kids develop cancer and they go through the same stem cell process. So we do use those processes. And like I said, we use it in Hurler syndrome, where we like to give it under 2 years of age, allogeneic transplants. So those procedures themselves are not excluded because they're younger. But when you go through a new technology like this, the regulators usually want to see that in adults, you've shown certain benchmarks before you apply it to young children. One of the other things we don't know in children is, if you're not going to suffer from the disease, and you know it's very difficult to predict, then putting you through a process like this may not be necessary. So that's a conundrum. It's difficult to answer that question right now. There's no question we know enough about Hurler syndrome that if we had a patient with Hurler syndrome at 6 months of age who's fully symptomatic, we would put them through an allogeneic stem cell transplant. And we know they're going to go through a rough time through that, but that's the only way we're going to reverse the course of the disease. But for Fabry disease, depending on the mutation, it may not be something that this is the right choice for. And I think that's something that has to be talked about individually. So, but as a technology itself, yeah, there's no reason you couldn't apply it to a younger age group.
Yeah. Okay, we have lots of questions coming in here. So the next one is, are there any other gene therapies in clinical development for Fabry? And if so, can you just outline what they are, data available, anything like that you can share?
Sure. There are in vivo gene therapies that are under development too. I don't have any data on those, but I think if one went to clinicaltrials.gov, they could contact investigators that are dealing with those trials to get information about them.
Okay. So the next question is, will it fix or reverse kidney damage? it was showed only 5 patients in the graph. Have only 5 patients been tested with ex vivo?
No, there were patients tested in Australia as well. What the current count is, I don't know. If somebody from AgroBio on the chat wants to indicate a number, we can go through the number. But 5 on the FAX trial, and that was the target recruitment. And then I think last count was 4 in Australia, so that would be 9 with the ex vivo.
Okay. And will it reverse kidney damage?
Reverse kidney damage. So scarred organ tissue is not going to come back from doing a gene therapy. The goal is generally to halt progression of the disease. But in some ways, it's a complex question, because if there's kidney damage and it's in a stage which may be reversible, so you have swelling of certain kidney cells, and if you corrected them, they're at that stage, and then you provided a correction, you may protect those cells from undergoing a final fate of cell death or scarring. But if you have significant end organ disease, like if you've had a stroke, the stroke is not going to reverse. If you have scarring in the heart, that's not going to reverse. If you have scarring in the kidney, that's not going to reverse. What it's doing is allowing you to make enzyme on a 24/7 basis, which is how your body would normally make enzyme. But any damage that's existing there is, we're not expecting that to go back to normal.
Yeah. Next one, does the specific Fabry mutation affect the ability to be eligible for gene therapy?
It's not specific to the mutation, but like I said, some null mutations where you have no enzyme activity and you produce antibodies if you received enzyme replacement therapy in the past, those ones would meet exclusion criteria because they have a high or severe adverse reaction to enzyme infusions. But it's not specific to the infusion. Why? Because we're not correcting the original DNA change in this trial. What we're doing is replacing it with a different gene, a sort of a synthetic gene cell.
Okay. Just while we're going through these, lots of really positive feedback, and thank you to you. Well, I'm reading these, Dr. Khan. So I think that this, having the forum to ask questions is so important to patients. So thanks so much for doing this, because I mean, the questions are great, everybody. So thanks for sending those in. This is why we're all here, and it's to get education. So thank you for just for being interactive with us, because this is so important. Another question for you: is there a hypothesis that this treatment provides enzyme levels which are high enough to prevent kidney heart failure and stroke, or does this simply just slow down the onset, similar to Fabrazyme, or sorry, similar to different Fabrazyme infusions and ERT?
So we don't have data that it's going to prevent any specific complication. Fabry disease is a chronic disease, and any intervention you take, it takes time to collect data to see if it did reduce the complication. We're not there yet with the timeline of observation. So what it's designed to do is provide you continuous higher levels of circulating enzyme, with the understanding that it's the, sorry about the sirens, with the understanding that deficiency of enzyme is what is producing the disease symptoms. So by replacing it, then we can slow down its progression. But whether it will prevent heart disease or kidney disease is based on the assumption that replacing the enzyme is what's supposed to help. Whether that turns out to be true, time will tell.
Great. Another question, our son is receiving ERT. If he stops ERT, could he be considered for the Avro gene therapy trial?
Depends on the age and whether those eligibility criteria are met.
And is it 3 years after? With the stop?
No, I don't think it was 3 years. I've got a bunch of numbers in my head, but I can
pull it up too while we're going through some of the ones. Yeah. Okay, to be up here 2 years. Yeah, they're just saying, yeah, he'll be 18 next year.
Yeah.
Yeah.
Yeah, 3 years. 3 years.
It is 3 years. Okay, yeah, so 3 years. Yeah, so 3 years and 18 next year. So I believe the US is 18, and for Canada, 16 are the ages. Will it ever be available?
I would not recommend anybody to stop ERT to get on the trial. Because you're 3 years without therapy, your standard therapy. So, but there are some people who have stopped for various reasons that might still be eligible.
Okay. Will it ever be available for women who have had a kidney transplant?
Well, I think over time what you expect with the studies is the inclusion criteria get broader. I can't speculate what might be available in the future. I think, if you looked at it from the safety standpoint and you said, suppose there was a kidney transplant done on somebody who developed leukemia and needed a bone marrow transplant, they would get a bone marrow transplant. There are ways of dealing with that. So, an autologous stem cell transplant that's gene corrected is usually less of an ordeal than an allogeneic transplant in a patient with cancer. So there's no technical reason why not, but right now that's not in the patient group that we're able to study in. Yeah.
Yeah, and I think, so just to answer, there's been a few questions about females here, and if we'll, kind of asking for dates, when would that maybe be open? And I think Dr. Khan, you did a good job of explaining, why at this point it's not, and we'll see what the future has for when that may be a potential option.
I'm very optimistic at some point we will be able to use this in females, and it's just at the very early stages right now.
Yeah.
Of the clinical trial.
Yeah. Okay. Well, you know what? Unless there's anybody else. Okay. Sorry, just one more. What is the best case timeline scenario for regulatory approval?
Okay. I'm seeing the chat now. Okay. For some reason, it was off my screen. Well, in general, the regulators want to see that the study is completed, right? So even if you go back to FACS had a 5-year follow-up, and we haven't completed that in the first patient. And then you decide at what point you make an application to try to get regulatory approval. It's not an easy answer. So these are typically, studies are in phase 2. They'll probably have to go through phase 3. I think there's going to be some work that needs to be done before we get to regulatory approval. Because those follow-up timelines will need to be met to show that, yes, safety and efficacy were followed over those timelines and the data is complete. I think if the timeline is too short and the study is not completed, there's not enough data to show whether it had the intended outcome that one wanted.
Yeah. Does this therapy assist with white lesions in the brain?
Again, if there are existing lesions, I don't expect it to improve those. But white lesions can be due to any number of things. So if it's scarring, I don't expect it to change scarring. If it's a diffusion effect, those could be due to any number of things. I don't expect it to reverse stroke or any signs or symptoms of stroke. The other white lesions that we see with Fabry disease, which have been very difficult to correlate clinically, what's called amaurosis fugax. We don't even know how much of a problem it causes. You see a lot of patients with Fabry disease have those white lesions. So if we're not sure what problem it's causing, it's hard to know whether fixing them fixes any real problem. But, bad analogy, sorry if it sounds a little off, but fixing the brakes after the car accident does not reverse the accident. So organ injury that has already taken place, we're not expecting that to reverse. whether it's an imaging finding on MRI or cardiac MRI or some other measure.
Yeah, that makes sense. With gene therapy, patients in the future could experience a lack of efficacy, meaning that the enzyme activity levels will go back to the pre-gene therapy levels. What is the future strategy with these possible cases?
Sure. So good question. Well, the question is that going to happen? The way it may be phrased is that that's likely to happen. It's actually not a likely expectation. There are different phases of going through learning about how well this has worked. So something we call early engraftment, where it looks like the transplant worked, everything's working, but then those cells aren't really happy in the long term, and they're like, oh, we're not going to stick around very long. So you could lose a graft. That would be the first thing to consider if the enzyme activities fall. Then there's what we call long-term engraftment, and it can take 6 months to 2 years to determine whether long-term engraftment has taken place. For the most part, if long-term engraftment has taken place, it's there permanently. Again, we see it in Hurler syndrome, patients that were transplanted under 2 years of age, even in their second decade, a certain percentage of them still continue to have enzyme activity. Some don't. We just can't predict it at this stage. And we don't have the assumption that it's going to go away. So if it goes away, what could you do? You could go back on enzyme replacement therapy or chaperone therapy or whatever was available and go back to treating things the way they were. Could you go through another round of that? This, I suppose you technically could. Again, if we go back to the cancer world, because there it's a matter of survival, people go through multiple rounds. They may go through more than one transplant to have the effect. That would probably be something you would look at a personal level, having gone through it once before, whether you want to go through it again. But that's, again, way in the future. We don't even know if that's the case for this situation.
Yeah. We'll take one final question here. And again, just thank you so much for everybody for the participation. Can we see the further information for the trials on the screen right now? Are the links up? I just want to make sure.
I do see the links up.
Okay, wonderful. Okay, thank you. Okay, we have a couple more questions, but I'm just going to try to find the one here. So how about the biomarkers with patients is the question.
Sure. So I don't know if anybody was, well, probably not. I mean, so I gave a talk at a meeting in London, England, I think at the beginning of the year, reviewing biomarkers. So there's many ways of looking at a biomarker. The way the regulatory agencies, the FDA or EMA, look at biomarkers, what we consider to be biomarkers, the GB3, lyso-GB3, actually don't fit the description. The reason is you can see some reduction in some patients, or you can classify patients with classical or non-classical disease, but you can continue to see disease progression even though your biomarkers don't fluctuate. So we don't always see a direct correlation. There hasn't been a proven clinical correlation between the biomarkers and disease progression. So we're not really sure what they mean. And there are certain therapies where you don't see a reversal of biomarkers in the blood or urine, but you do see changes in the tissue that are positive. So it's hard to say in the long run. Should we be measuring them the same way? Are they having the same effect? It's hard to know. We do have data on biomarkers. I didn't present it because it would be more slides. It's not that straightforward to interpret. So if you look at some of the isoforms of lyso-GB3, it looks like some are doing better, some are not doing better, and we're trying to figure out how to interpret those.
Yeah. Now, I know that was the last question, but I do think this one's important to touch on real quick. It's just asking how many of the FACTS trial patients have stopped their ERT or restarted ERT after gene therapy?
So, I mean, I think because, with these trials, of course, we don't want to release information preferentially to one group or another. So what we've released publicly, meaning to say that it's been released before, so you're not hearing it for the first time from me, is 3 people have stopped their ERT.
Okay. Well, great. That seems like a good thing to end on. So thank you so much. Thank you to everybody for all being here, for joining us. What a wonderful webinar. That was wonderful information, and you do such a wonderful job of explaining. So thank you. Thank you for your time and for everybody being here. Lots of thank yous coming in, so we really appreciate it.
Thank you all very much. Take care.
Thanks, Dr. Khan.
Bye-bye.
Thank you, Julia.
Thank you, Jerry. Thank you, Jack.
Thank you very much. Very informative.
Yeah, thank you.
Thank you so much.
Wonderful. Thank you. Thanks for being here.
Okay, now I'm gonna go eat ice cream and watch TV.
Yeah. Wonderful. Take care, everybody.
Thanks, everyone. See you, Julia.
Yep. You too. Bye.